activity on COVID-19. When it comes to hemodynamic management of COVID-19, so I purposefully kept extrapolating existing evidence because we are already aware that lots of things are happening in terms of therapy, diagnosing, and its atypicality of clinical presentation and a research based on vaccine development and all. But when it comes to hemodynamic management, we are still trying to apply the existing our evidence and the experience in relation to the COVID-19 manifestation. So when it comes to hemodynamic management nutshell together, so we have to discuss something in relation to proper hemodynamic monitoring and a bit in and around the fluid therapy. So these two aspects maybe in another 40-45 minutes I'm going to deal with. So maybe like before 2019 December, we were not aware of anything like COVID-19, that is novel coronavirus or SARS-CoV-2. So from Wuhan in China, when they reported this so-called COVID-19, so probably from bats to pangolin to human beings. So that was how the story of SARS-CoV-2 has been started. So after that, slowly trying to understand its pathogenesis. When it comes to hemodynamic monitoring, so three things you have to remember when it comes to viral entry and pathogenesis. You remember this novel coronavirus, that is a beta coronavirus group of RNA virus, which is having something called spike protein. So you have to remember three names here. One is the spike protein, one is the ACE2 receptor, one is the type 2 transmembrane serine protease enzyme, which helps in breaking up of this ACE2 receptor so that it makes the entry of this beta coronavirus through this spike protein attachment into the cells. So basically, there is something called spike protein on the surface of this coronavirus, which will attach to ACE2 receptor. So protease enzyme, which helps in breaking this ACE2 receptor and make the viral entry into the cell. So after its entry, so our main important concern in relation to hemodynamic monitoring, we need to understand what is going to happen in the primary organ which is going to damage, that is the lung, and what is the impact of this COVID-19 and other organ outcome. So when it comes to lung, so we know that initially, like lots of theories proposed, COVID-19 will create a problem which is similar to that of the ARDS. So basically, so in the lung, so leaky capillaries, interstitial edema. So then, like all the cytokine storm will be there. So again, it makes the scenario worst by activating again this breaching the endothelium and all. So which again potentiate the possibility of the interstitial edema, that is a non-cardiogenic pulmonary edema. So basically, so lung will have some problem which is similar to that of the ARDS. When it comes to other organs, so this cytokine storm, particularly interleukin 1, so interleukin 6 and TNF alpha can have damage on the endothelium of the vascular system, so which leads to exposure of subendothelial collagen tissue, so which can activate something called procoagulant status. So because of that, so which can lead to microthrombi formation in the perfusion of different organs. So it may be liver, kidney, and virus itself can have an impact on the heart, which can cause myocarditis. Again, so once organs get damaged, again there is a activation of the cells and release of the cytokines, again which will have an impact on the lung. So this is a vicious circle. So in between there is an involvement of the complements and development of the antibodies. So basically, so the well explained pathogenesis in relation to COVID-19 is its cytokine storm, which leads to some sort of all these clinical manifestation of different organs. So, how a shock develops in COVID-19? So, what is its pathophysiology? As I already told, so it's a viral infection, so which have an and inflammation. Because of the cytokine storm, there will be peripheral vasodilation. So, effective systemic circulation will come down. So, hypotension, leaky capillaries, non-cardiogenic pulmonary edema that is in the lung. Again, because of the inflammation, which again potentiate the capillary leak, so endothelial activation, low coagulant state. So along with that, because of the microthrombi, so tissues will suffer from the hypoperfusion with manifestation of high lactate and organ dysfunction. So basically, so something which is going to happen in relation to vasodilatation, leaky capillaries, some microthrombi, some shunting is going to happen at the tissue level, which leads to organ dysfunction. So all these theories we already explained and experienced even in sepsis also. But this virus, other than these manifestation, can have shock for some more reasons, because when you see the data from Italy and Spain, so most of the young patients, they had sudden cardiac arrest, then they evaluated, they found to be having myocarditis in about 7 to 12% of the patient. So also they had some malignant arrhythmias and cardiomyopathy. So it may be a direct impact of the virus on the heart, or it may be impact of the cytokine storm. So again, other manifestation which is related to shock is like pulmonary thromboembolism. Lots of data available because of his procoagulant status. Patient can have obstructive shock. So in relation to pulmonary thromboembolism, there are few like case reports. So it also caused some cardiac tamponade. So other main important reason for shock. So everywhere we know that there are lots of discussions are happening. So keep the COVID patient with a negative balance. So, but if you jump too much negativity from the beginning itself, because in about 10% of the patients, COVID-19 can manifest with shock also. So when you restrict the volume from the beginning itself, so then there is a iatrogenic shock in COVID-19 patients. So this is how an hemodynamic manifestation of COVID-19 in relation to different organs is going to happen. So properly when it comes to hemodynamic monitoring, I already told. So currently we are understanding and we are applying our known knowledge in the hemodynamic monitoring when it comes to COVID-19 also. Again, what different? So I already told like we are trying to extrapolate the evidence and the experience, but is it any difference as compared to non-COVID management? So we need a bit frequent fluid challenge, because at the end of the day, after initial resuscitation, we don't want too much positive fluid balance. So then a little bit we need to understand when it comes to hemodynamic management. So we need to understand the which phenotype of the patient we are treating. So lots of discussions has been happened. So there is something called L type, there is something called H type. It depends upon the lung compliance. But remember, so this concept looks new, but it applies to our existing ARDS patients also, because in a single patient, initially a patient who is having a L type, that is with a good compliance, down the line with the complications, with a superadded pneumonia, with a ventilator-induced lung injury and all, they can move from L type to H type. So it is nothing new, because see there is some theoretical rationale, there is some existing concept that's been already extrapolated into the COVID-19. So we need to understand when we are ventilating this particular phenotype, this ventilation can have an impact on the hemodynamic monitoring. Modality of the ventilation can have an impact on the hemodynamic monitoring. Again, in the L type, we have to be very worried about the PEEP, because PEEP is directly having an effect on the hemodynamics, which I will discuss later. Again, keep in mind, so when patient is going to have new onset of shock, don't think it is only septic shock with a superadded bacterial infection. Couple of patients, good number of patients also presented with pulmonary embolism in-house when they started treating this novel coronavirus. So we need to monitor RV function when it comes to COVID-19. These are some differences when it comes to hemodynamic monitoring as compared to non-COVID patients. Again, like basically I told we worried about to maintain a adequate fluid balance. Means like we don't want like too little also, too much also. The impact of too little fluid management, so it leads to hypovolemia. So prematurely we'll land up with starting vasoactive agents. So remember, so norepinephrine is bad in an hypovolemic patient, because so hypovolemia with a norepinephrine can cause organ hypoperfusion. So again, with the decrease in effective systemic circulation, again, which also compromise the tissue oxygenation and organ failure. Suppose too much volume. So there are lots of studies which demonstrated that cumulated fluid balance at 12 hours and fourth day after initial resuscitation is having a direct correlation with the mortality and increased ICU stay and ventilator days. So because this positive fluid balance will create the tissue edema again, so intra-tissue perfusion pressure is going to be hampered, so they will not get adequate perfusion which leads to organ failure. So both are bad. So whether patient is in sepsis or septic shock, or when a patient is moved for surgery, so we need to understand we need an adequate fluid balance. We don't want less, we don't want more also. Again, so suppose if you understand, like in any hemodynamically unstable patient, if you give some sort of intravenous fluid bolus, hardly 50% of the patients are going to respond to the fluid bolus therapy. So another 50% we are going to do harm. See, most common reflex to give a fluid bolus in ICU is like low urine output or hypotension. So in our rounds also, most routinely what we'll do, if our sister or the resident who is going to inform, sir, patient is having low urine output from couple of hours or is having hypotension, we'll tell them give the fluid. So remember, in that scenario, hardly 50% of the unstable patients are going to respond to the fluid therapy. Another 50% might not respond. They need other therapies other than the fluid bolus. Again, when we need monitoring, so first and foremost, it comes is clinical monitoring. We have some three windows of our perfusion. One is the brain, that is the altered sensorium, so kidneys, urine output, and the skin temperature. But remember, all these clinical manifestation will give a cumulated effect of hypoperfusion. It's not a live program. So when a patient is having a decreased urine output, it understood is already having an hypoperfusion from couple of hours already. So clinical windows helps in putting everything together along with hemodynamic monitoring. Again, like this is the overview on evaluation of monitoring. So we know that there are lots of limitations of just measuring the blood pressure, because blood pressure so depends upon the flow at the extremes of flow. If the patient is in shock or hyperdynamic circulation like sepsis, initial part of the sepsis and all, BP may be high or low, but so they are going to have the perfusion problem. So blood pressure is not a direct correlating with the perfusion of the tissue. And we had central venous pressure monitoring. We know that lots of things, lots of assumptions when we measure the CVP. So we assume first pressure is equal to volume. So right side is equal to left side because CVP is the right atrial pressure. So that is equal to right ventricular end diastolic pressure is equal to pulmonary artery occlusion pressure. So that is left atrial pressure, left ventricular end diastolic pressure. We assume that left ventricular end diastolic pressure is equal to left ventricular end diastolic volume. So we are basically interested in left-sided preload. So lots of assumptions in between right to left, pressure to volume. Anything which happens abnormality in between, so CVP may not be a good indicator of fluid responsiveness or preload deficit. See, low CVP we can give some value. Okay, might be patient is having a hypovolemia, but high CVP, lots of confounding factor. The patient is having pneumothorax, pleural effusion, intra-abdominal pressure. Anything can kick off the high CVP. Remember, so measuring the CVP is very easy, but measuring the CVP optimally in an ideal condition is very difficult because we need to measure the CVP at the end of expiration and end of diastole because we are interested in end diastolic volume. So we need to freeze it. Okay, we need to identify the PR interval. So end of A wave or end of C wave, it's not so easy, it's cumbersome. Again, pulmonary artery catheter. So again, it's also pressure based indices. So lots of complication, lots of morbidity, too much invasive. Even though we'll get a very good idea about the cardiac output, but so risk is more in terms of complication. Echocardiography, it is very good gadget in even in COVID-19 patients also. Non-invasive, repeatability is there. Quickly we can do with a minimal training. The problem is there are some subjective variability will be there, but that we need to understand and accept. When we move on to invasive monitoring, so here we are trying to do heart-lung interaction, and we are trying to assess, and we are trying to analyze the heart-lung interaction, which may be pulse pressure variation, so systolic pressure variation or stroke volume variability. There are a couple of non-invasive monitor which also gives the same parameters. So together, this is the dynamic assessment of the hemodynamic monitoring. When it comes to static, so these static parameters like CVP and pulmonary artery occlusion pressure will not tell much about the heart-lung interaction. So it means what is happening to the cardiac output in relation to, so changes in the lung in relation to inspiration and expiration. These parameters will not tell. So the dynamic indices like pulse pressure variability, stroke volume variability will tell about the heart-lung interaction also. Again, when we need some sort of advanced hemodynamic monitoring, even in COVID-19 patients. So I told, the majority of the COVID-19 patient, near about 80%, will not require any sort of hospitalization. In about 20%, those who require, means like hospitalization. So 10% are too much critical, they require invasive ventilation, so with a proper mechanical ventilation and all. So they might develop the shock in the due course. Or if they manifest with the myocarditis, pulmonary embolism, or because of the too much fluid restriction, they can straight away have the hypovolemia and shock manifestation. When it comes to indications for hemodynamic advanced hemodynamic monitoring, like we need some cardiac output monitoring. The patient is hypotensive despite adequate fluid resuscitation, or if the patient is having an ongoing evidence of global tissue hypoperfusion, like he's still having high lactate or decreased urine output, like cold peripheries with the ongoing fluid resuscitation, we need some bit advanced hemodynamic monitoring, or with a shock when they manifest with mixed pathophysiology. So assume a patient who is having a coronary artery disease, because the sicker manifestation in COVID-19 occurs in elderly patients with some sort of comorbidities. A hypertensive coronary artery disease patient came with pneumonia manifestation, that is COVID-19. So we don't know so what pathophysiology is contributing to shock. So then in a mixed pathophysiology, we need some advanced hemodynamic gadget to tell, to narrow down what kind of shock currently we are dealing with. Again, if a patient is subjected to some major surgery on basis of emergency, some vascular surgery or some sort of surgery where there is a major fluid shift, we require some sort of hemodynamic monitoring. Again, so can we use cardiac output? Is it a better than that of the perfusion marker than that of the blood pressure? Definitely yes, because this was the age-old study in 1944. They showed, so before the onset of fainting in patients, still they were having a adequately maintained blood pressure. So when it comes to cardiac output, so which correlated with the symptomatology, so cardiac output falls early as compared to blood pressure as a marker of hypoperfusion. But don't think cardiac output, if you improve, is going to serve the purpose, because it is a tissue utility at the cellular level that comes like a final pathway for the utility of this fluid to give a adequate perfusion. Even though if you have a good cardiac output, it doesn't mean that they are going to have a adequate perfusion. It depends upon the tissue utility. But still, cardiac output helps in better understanding of perfusion as compared to blood pressure. So do you think is there any normal cardiac output? This we need to understand. There is nothing called normal cardiac output, because cardiac output is a relative phenomenon. So I am sitting now, I am speaking to all of you. So my requirement of cardiac output to perfuse my organs may be around 2 to 2.5 liter. Suppose if I started jumping and doing exercise, my cardiac output requirement to satisfy my tissues may be around 4.5 to 5 liter. So basically, this is a relative phenomenon. This is a supply demand match. That's why studies with the target supranormal cardiac output, they were not have any good outcome. So instead, they done the more harm just to increase the cardiac output more than 5 or 8 to a particular number. So it is basically supply demand match. It's a relative phenomenon. Again, what are the different methods of cardiac output monitoring? Clinically, I told with the limitations, we have non-invasive monitoring, minimally invasive, invasive. So non-invasive may be Starling principle, bioreactance, bioimpedance. Minimally invasive like Vigilio monitor, that is the flow track. So invasive monitoring, that is the Volumio, Pico, and pulmonary artery catheter. So So these are the overall available devices in the market. I will not go into the principle of each device. So we'll narrow down our discussion to COVID-19, what with their understanding their limitations. Again, so I already told we have a static parameter, that is a CVP and pulmonary artery occlusion pressure. We have a static volume indices, that is global end-diastolic volume and left ventricular end-diastolic volume. So then we have a dynamic parameters like PPV, SPV, SVV. When you measure the single reading of IVC, so it's a static. When you see IVC variability or distensibility index, then it become like dynamic parameter. So hierarchy of preload assessment. So PPV is bit better than the systolic pressure variation, which is better than SVV and left ventricular and diastolic area. So lowest, so preload assessment predictability is with the CVP and pulmonary artery occlusion pressure. Again, before we move on to the COVID-19, we need to understand a bit on the heart-lung interaction. So even the concept remain same in COVID-19 also, but we need to understand what modality of ventilation we are following in COVID-19. So when a patient is on positive pressure ventilation, during inspiration, so there will be increase in transpulmonary pressure. So in the same time, so there will be increase in intrathoracic pressure, which becomes more positive. So after effect of this is there is a decreased venous return. So decreased RV preload because of increase in transpulmonary pressure, which increases the RV afterload. So LV preload is going to be increased because of this positive pressure ventilation. There is a squeezing of pulmonary veins, and they are going to empty into left atrium into the left ventricle, which overall increases the left ventricular preload. So when it comes to left ventricular afterload, there is something called transaortic transmural pressure. Because of intrapleural pressure is becoming positive during the positive pressure ventilation during inspiration, overall the difference of intra-aortic and intrapleural pressure will become decreased. So obviously, so this is going to help in so overall improving the LV preload and decreasing the LV afterload, overall increasing the LV stroke volume. So indirectly, there is a increase in pulse pressure during inspiration during positive pressure ventilation. So when you are ventilating a patient with hypovolemia with COVID-19, suppose I told you are restricting lots of volume in COVID-19 because you don't want the positive cumulated fluid balance. So when you give the inspiration, there is a more and more collapse on the IVC, more and more pressure on the RA. So basically, right-sided preload is going to be decreased. In the same time, because of the increase in transpulmonary pressure, right ventricular afterload is going to be increased. So because of squeezing of zone 1, west zone 1 and 2 capillaries, which are going to emptied into the left atrium and left ventricle. So overall increase in left ventricular preload. So decrease in left ventricular offload, which tries to increase the overall left ventricular cardiac output. But this phenomenon is going to be exacerbated if the patient is going to have severe hypovolemia. So there is a severe decrease in right ventricular preload if we are ventilating with a positive pressure ventilation in COVID-19 scenario. Again, so can we use this PPV value? Because when it comes to using hemodynamic monitoring, we are speaking in and around. So using this hemodynamic method in ARDS patient in relation to mechanical ventilation. We need to understand when a patient is having some sort of hemolytic toxicity, is having hypertension. So then if this PPV is more than 12 to 15%, we have a cutoff of PPV about 10 to 12%. If significant PPV is there, so then effect of increase in PPV is because of heart-lung interaction because of the mechanical ventilation. So it may be because of relative or absolute hypovolemia, or if the patient is having severe right ventricular dysfunction, so then also he can have a increased PPV. Remember, patient is having some sort of hypotension. So we measured the PPV, PPV is elevated. So then it is because of heart-lung interaction. So that might be because of hypovolemia or RV dysfunction. So indirectly we have to see for is there any RA-RV dilatation. So is there any so large like dilated IVC, elevated CVP. So then our modality should restrict the fluid. So we have to consider using norepinephrine and some other measures of optimizing ventilation with driving pressure, P plateau, and we can consider rescue therapy of the prone ventilation. Suppose if the patient is having a non-dilated RV, IVC is still small and collapsing, low CVP with the background of elevated PPV, we have to consider giving the fluid resuscitation or continuing the fluid resuscitation with understanding the risk and benefit. So this is how we can club together hemodynamic monitoring in ARDS patient with the background of mechanical ventilation. Again, we need to go in depth in monitoring in relation to particular phenotype of this COVID-19. I already told this phenotype is a so different manifestation with the same spectrum of the disease. A patient may be initially in the L phenotype, means low elastance, it means very good compliance, low ventilation perfusion ratio, because here there is a loss of hypoxic pulmonary vasoconstriction. So they are going to have less lung weight. Lung is not too much wet and weight. So they are low recruitable because so non-irritated lung is very minimal during that phase of ARDS. You have to remember, so recruitability will help in a patient who is having a diffuse infiltrate, not in a localized infiltrate. Again, if the scenario worsens, so they can move to H phenotype, low compliance, high right to left shunt, high lung weight, and high recruitability. So depending upon what phase the patient is having. So how we can relate this phenotype to hemodynamic monitoring? Suppose if you assume this is a scenario 1, so he's having a L type, means compliance is more than 50. So X-ray or CT shows minimal infiltrates. So he is having a loss of hypoxic pulmonary vasoconstriction, which means there is no elevated pulmonary artery pressure. So when it comes to hemodynamic strategy in L type with a good compliance, so because the patient is having a compliant lung, so transmission of airway pressure is easily going to happen into the pleural space. So when there is an increase in pleural space pressure, so positive intrathoracic pressure will decrease the so venous return and RV preload is going to get affected. Again, suppose in an L type of patient, if you give high PEEP and if you try repeated recruitability in that, so again, whatever the pressure maneuver we are trying, that will transmit it into pleura. So that will compromise again RV filling. So again, it applies like if you suppose go haphazardly and crosses the PEEP plateau of more than 30, so that will again have an impact on the abdominal pressure and collapse the IVC. So again, compromise the RV preload. So in that condition, you have to make sure the patient should not suffer from hypovolemia with this kind of ventilation in L type of phenotype of COVID-19.
वो तो माला माल तो आया 1.5 महीना हो गया, वो तो उसको गया ही 1 महीना हो गया जाए.
Positive balance after initial resuscitation. So then only we have to consider avoid positive fluid balance. Again, so when we consider this so-called dynamic indices like PPV, SVV, so can we use in this scenario of the L type of like phenotype? You have to remember. So basically, so when we consider ventilating this L type, we might not require strict ARTSNet protocol like very low tidal volume kind of this one. If the patient is on adequately like maybe around 8 ml per kg, still we can use dynamic parameters like PPV and SVV. If the scenario is like type 2, so we know that the compliance is poor, so X-ray shows bilateral bad infiltrates. So typically in this condition, we'll stick on to lung protective ventilation with a low tidal volume and high PEEP. So because they retain hypoxic pulmonary vasoconstriction, they suffer from high pulmonary artery pressure. So less transmission of these airway pressures into the pleural space, but there is an hand-in-hand increase in transpulmonary pressure, which will affect the RV afterload. In the previous scenario, RV preload is going to get affected. Here, RV afterload is going to be increased. So then in this condition, so recruitment maneuver so may help on individual approach. Again, if you see, we have to ensure adequate afterload reduction in this scenario. Might consider using pulmonary vasodilatation. That's why maybe in near future we have to expect like maybe innate nitric oxide or prostaglandins might help in reducing this pulmonary vasoconstriction. So again, the PPV and SVV, which are our dynamic parameters, which are going to give false negativity if they are strictly on low tidal volume with a poor compliant lung, because they are etched up, the compliance is very bad. So whatever we give this low tidal volume is not enough to mimic the heart lung interaction to mimic changes in PPV and SVV. Again, if they are having a RV dysfunction because of any reason, because of the PEEP, high PEEP or whatever it may be, which can have false positive report that may increase the PPV and SPV, which I discussed in my previous slides also.
So
And
this
in this condition, can we use something else, like if they are on low tidal volume ventilation, we can consider this is so-called tidal volume challenge. So measure the PPV and SVV baseline. So then from 6 ml go to 8 ml. So then if you see the change in PPV or SVV, that is the delta PPV or delta SVV, if it is more than 3.5 and 2.5, which have a good predicting in fluid responsiveness during this so-called tidal volume challenge test. So which helps in unmasking the situation. So initially, which gives a false negativity because of 6 ml. If you give a 8 ml, which may help in unmasking the patient's fluid responsiveness. Again, so when we monitor COVID-19 patient, we have to give bit weightage to the RV function also. So consider clinical examination, optimize the PEEP, okay, depending upon the phenotype of the ARDS, optimize the volume status, use echocardiography. If you have advanced monitoring, go for extravascular lung water index and all. But when a patient had new onset of shock, so again, use echo and other hemodynamic modalities. Here you have to differentiate because in about 8 to 10% of the patient, they can have superadded bacterial infection, sepsis as the cause for shock. So if they are having a wide pulse pressure, so low arterial tone with a decreased systemic vascular resistance with a high cardiac output, so then it moves towards the septic shock. But if the RARV is dilated, so then we have to exclude pulmonary embolism also. So basically, you need to understand throughout the journey of hemodynamic monitoring in COVID-19, we have to consider heart-lung interaction, what modality of the COVID-19 we are treating, what ventilator strategy we are using, and we have to give weightage to the RV function monitoring also. A bit on passive leg raise test. So because we already learned lots about this, so passive leg raise test, it's an independent of heart lung interaction. It is an auto transfusion. So self-limiting. There is no need of external fluid bolus for this. It is a reversible. So again, one benefit is irrespective if the patient is on spontaneous breathing, arrhythmia, low tidal volume, we can use passive leg raise test. But before PLR, so you have to ask some question. So is patient require challenge or resuscitation? Suppose a patient came with, like, because you remember COVID-19 can manifest atypically with bad gastroenteritis and all. They can have hypovolemia because of loose motion. The patient is having obvious hypovolemia. During that time, don't think, okay, I will do PLR and will check for the fluid responsiveness. Okay. So just ask yourself, patient require fluid challenge or resuscitation. Initially, if there is an obvious hypovolemia, just resuscitate them. Don't keep on doing this PLR and all. Again, next question you need to understand, is the perfusion pressure you are able to increase by increasing the cardiac output, or you can do the same thing by giving vasoactive agent. So that you have to understand, because whenever you are doing the PLR, it means you are trying to increase the perfusion by giving the fluid. That means by increasing the cardiac output. That you need to understand. Again, so when you do the PLR also, after PLR, what you are going to do? Suppose the patient already crosses the safety limit, like his lungs are very badly congested, very bad infiltrate, very bad hypoxemia, then still before jumping on the result of PLR to give the fluid, you have to think like very much before you give the fluid in that condition also. Again, so after PLR, if you get, if the patient is in the like steeper portion of Frank Starling curve, so you can think, okay, you can give some more fluid. Again, reassess, keep the trend of this PLR report. So then if the patient move towards this flatter portion, you stop doing giving the fluid bolus. So suppose if you get like stroke volume change after doing the PLR, if it is more than 10%, so you have to get a stroke volume baseline. So give the PLR for 45 degree for 1 minute. So at least that time is required for the transfusion of minimum 300 ml volume from the lower extremity and the splanchnic circulation into the heart. So then if the change in stroke volume, if it is more than 10%, still you need to understand, is my patient require fluid or not? Because fluid responsiveness doesn't mean always we need to give the fluid, because normal heart, okay, normal human being is having an heart as a compensatory mechanism is going to have a fluid responsiveness, because if you throw about 500 ml into a healthy heart, it is going to have an innate good pumping activity. It is going to kick that volume through the left ventricular cardiac output. So you have to analyze clinical parameters of hypoperfusion along with the fluid responsiveness. So fluid responsiveness always doesn't mean you need to give the fluid, because normal heart is also fluid responsive heart. Again, like pitfalls of PLR. So in COVID-19 condition, risk of exposure. Multiple times you have to go near to the patient, do the PLR. So it's not so easy. There is a high possibility you might get exposure to the infection. So we need a real-time cardiac output monitoring. You can't see the change in blood pressure or change in heart rate after doing the PLR. You need a real-time cardiac output monitoring. So because the sustainability of the PLR is going to happen only for 90 seconds. Maximum effect of PLR is going to be in and around 1 minute. So it's going to be weaned off because of the redistribution. If the patient is having leaky capillaries, so this effect of PLR is going to be ill sustained. So there are some contraindication, raised ICP, severely increased intra-abdominal pressure with intra-abdominal compartment syndrome. So we might not able to do the PLR in that particular patient. Again, there is something called functional hemodynamic monitoring in COVID-19 also. Suppose if the patient is having circulatory failure, okay. So next question, as I already told, is there any signs of requirement of absolute hypovolemia? The patient is having hemorrhagic shock, severe hypovolemic shock with the background of gastroenteritis. Obviously, they need fluid. Give them the fluid, not the fluid challenge. So we need to resuscitate them. After that, if there is no such obvious requirement of the fluid, so then you have to ask yourself, if the patient is having spontaneous breathing, arrhythmia, low complex and low tidal volume, so then we can't use our dynamic parameters like PPV, SVV and all. So then we have to go to some maneuvers like those which are independent of this heart lung interaction, like PLR, end expiratory occlusion test and mini fluid challenge. So again, if there is no contraindication like spontaneous breathing, arrhythmia and all, we can use PPV, SVV, and we can assess if my patient is going to require fluid or not, depending upon the cutoff value. Again, a bit on end expiratory occlusion test. So here, so at least patient requires endotracheal intubation and he should be able to withhold the breathing for 15 seconds. Should not have a spontaneous breathing effort at least for 15 seconds. Again, patient should have some cardiac output monitoring, preferably pulse contour analysis. If the cardiac output increases by 5% after giving end expiratory occlusion for 15 seconds, which predict the fluid responsiveness in that particular patient. Again, mini fluid challenge. It looks interesting because here you need to give 100 ml of colloid over 1 minute. But the problem is you need a very good sensitive gadget to pick up the fluid changes, means cardiac output changes induced by this mini fluid challenge, that is about 6%. So practically it's very difficult, but having a good theoretical rationale. Again, when it comes to non-invasive monitoring in COVID-19, because we need to understand more and more intervention, more and more invasiveness, more will be the probability of getting infection with COVID-19 with the highest infectivity. Again, can we use some non-invasive monitoring? So currently, so still we don't have very good calibrated data and all, but definitely these non-invasive monitoring are user friendly, give some idea about what is happening to the patient. If you see, even though there is a question about the accuracy and the calibration, but they are user friendly, still you can go for them in this current era of high infectivity with COVID-19. And one of that so-called non-invasive hemodynamic monitoring is Starling technology, which use four non-invasive sensor pads, so applied to the thorax, which we can put in the prone or in the supine position also. So small electric current is going to flow across the outer part of the these kind of sensors. So they are going to record voltage signal. So there is something called time delay or phase shift. So based on that, it gives a cardiac output monitoring. Suppose when you do PLR using the Starling technology, which gives the values like change in stroke volume index, so our stroke volume that is more than 10%, so then we can presume patient might respond to fluid challenge. So this is one concept. So we can use both prone ventilation and supine ventilation, user friendly. We can consider at the bedside in COVID-19 patients also. Again, so this is the utility of different dynamic indices and their limitations. So if you see, even our conventional fluid challenge, so to tell about whether a patient responded to volume or not, we need some cardiac output monitoring. But the problem here is how frequently you are going to repeat the fluid challenge. Suppose if you repeat maybe with the 500 ml, 300 to 500 ml, or about 4 to 6 times in a day, it will itself will add near about 2 to 2.5 liters. So that is not acceptable when you are like after the initial phase of resuscitation. Again, so some practical aspects we have to consider in hemodynamic monitoring in COVID-19. So adhere to PPE even with a both suspected and confirmed patient. That's very important. Without personal protective equipment, don't do any sort of hemodynamic monitoring or any experiment at the bedside. So non-invasive, minimally invasive, maybe a flow track, minimally invasive. With the existing arterial line, we can connect and we can see the SVV and we can run the PLR on that minimally invasive monitoring also. Follow your gut feeling. So suppose without any hemodynamic monitoring, if you feel with your thorough clinical examination, clinical knowledge and all, if patient looks hypovolemic, give them the volume. Don't think you need a always hemodynamic monitoring in all the patients and all. So take the monitoring display out of the cubic where you are monitoring. Like if you have an extension wiring and all, you can keep the console outside so that you can monitor without going inside the patient area. So use the clinical data to anticipate the problem. So remember, monitor just helps, but you need to integrate your clinical data, biochemical data along with the monitor data, because monitor itself not save the patient. It is your therapy. It is